All righty. Well, we are back with another PCBH Corner, and I couldn't be more excited to have this upcoming conversation with Dr. Alli Allmon Dixson. And we just went over her titles. She is a pediatric psychologist by trade. She's the second section chair for integrated care. She is a BHC who works in pediatrics, and then she's behavioral medicine faculty. And today's topic is going to be focusing a little bit more in on the behavioral medicine faculty part. And as Alli and I were talking before we started recording, there's not a lot of information out there in general about the role of a behavioral health faculty, behavioral medicine faculty, BHC faculty, as we were also saying, all the different names, or
All of
behaviorists, all of them. There's, there is information, uh, but we thought that it would be helpful for folks out there to kind of hear straight from the horse's mouth from Dr. Allmon Dixson, who literally just went through this process. So when were you hired for your role as behavioral medicine faculty?
So I was approached last October and then in 2022. And then I became the behavioral med faculty in May of 2023. So still pretty new, or about, 6 going on 7 months in. So while I'm excited to talk about my role, I also still have a lot to learn, which is great. I talk to the residents about being a continual PDSA. So am I in every one of the hats that I wear. So
Oh,
yeah,
I love
thanks for
that so
having me.
much. Yeah. I mean, this is the perfect time, in my opinion, to do this because it's fresh and a lot of the things that you've already gone through, you could speak to because right now it's January 30th. And so, yeah, you're still several months out from your 1 year
Yeah.
anniversary. And so there might be other folks out there that are about to start this journey. And I think that you're going to have some nuggets for them. So super, super excited to get into the conversation here. So yes, you started uh, in May of 2023. And do you want to tell the audience what your specialty is, and then kind of what the new role was calling for with regards to
Yeah,
the the
definitely.
setting?
So, being a pediatric psychologist, my area of expertise is pediatrics. So, definitely had the mindset in coming into this. What do I do when my competency sort of caps out at about 22 years old? And how do I make sure that I'm as supportive and knowledgeable for the residents that they deserve? I want them to have a really good learning experience, and I want to be a part of that. And so, when I was first approached by this, my mind immediately went to, oh, this probably isn't for me. It probably for the perspective of I just wanted to make sure that they got what they needed. And being a ped psychologist who I'd really planned to be the most amazing and passionate pediatric BHC and see as many patients as possible and provide systemic change within that role. That was really my goal, whenever I first stepped into integrated care. And so thinking about that transition of how you go from that and that specific piece that you have and those skills that you hold to transitioning it to a family med residency faculty member, it took a lot, but a lot of it, what it took is creating a team and a cohort around me of people who've done this in the past. And so I definitely had a lot of, imposter syndrome to begin with. Bridget talked to me a lot about that in our consulting time, which is great. But really, I tried to lean on previous experiences that I'd had with the residents. And then for me, I really just sought out consultation from everybody. So, fortunate for me and the residency, right after I was approached, was CFHA. And so I'd actually, whenever I was first approached by them, I always say, like, I'm really humbled to have this opportunity and this experience. And I'm going to need to ask some people. I'm going to need to talk to some people who've done this before. And so I reached out across the country to a bunch of colleagues and got names of people who are in this role or who've made this transition, which was really important to me. So somebody who was in a PEDS role and then transitioned into family med and how that went from them. And so at CFHA, I stalked those people. I kept a list of them. I hunted them down. And then I connected with them and I took their advice. And I think that the takeaways from those discussions that I had were so important because there's just a dearth of knowledge about what this would be like, and there's not a manual on how to do this. So yeah, having that's been vital.
That's a great segue. So from those talks, are there any specific nuggets that are sticking out in your head of what they told you about the role, or what would be an easier transition, what might be more challenging, or where to get information? Like, what did you walk away with of where to get started with this?
Yeah, absolutely. I think people had, depending who I talked to, they had different advice. And we've talked about this so many times, but I'm a functional contextualist at heart as well. And so one of the pieces that I always go back to is like, what are my values? What are my whys in everything that I'm doing? And what's the context with which I'm functioning? And so I had that, and I had that core that I kept coming back to. And whenever I was talking to them, one of the things that kept coming back to me, and after one of the conversations at CFHA right after, was a light bulb went off a little bit of like, oh, I'm training and supporting one BHC at a time as the section chair for integrated care here in our health system. I'm supporting patients in my clinic. I'm training my clinicians. Sometimes I get some residents or some med students, but of course, if I support the primary care clinicians before they're even in their clinics, I could have the largest impact on patients.
Oh,
A career that probably I'm ever going to see. And so when that light bulb went off, it became, instead of like, oh, I don't know if I can do this, to how can I do this? Like, what is it that I need to do to make sure that I have the skill set, or that I'm working towards the skill set, and gaining the skills that I need so that I can be this faculty member and give them what it is that they need, which is oftentimes like the support in their own context and understanding that. So after the conversations, I sort of left with like, this can fit for me and my why, and it does. Two, it's an incredible opportunity, and there's actually not a ton of us, which is, I think, one of the things that I didn't realize until I tried to find information about this. And then the third one was get consultation. So having those three things in my mind, I think, was really imperative, and it really helped to guide pretty much all the steps that I took from there.
what organizations? Well, obviously you mentioned CFHA.
Yep.
What other places did you find information, and what kind of information existed?
Yeah, so STFM, so the Society for Teaching of Family Med, is super helpful. I think that there's a lot of information on there. They even have a fellowship that's going on. So I think that is a great resource to look at. Become a member of STFM, I think, is important so that you're staying up to date. But one of the things that I found, given my history and role, is that a lot of the information on STFM and other places that I looked were really about not only becoming the behavioral med faculty role specifically, but about adjusting to primary care. And so that was interesting to me, primarily because I'm coming from this context and this mindset of I'm already doing that. And so thinking a little bit about how do I make sure that I'm taking the knowledge that I have in the context that I've already got and really honing that,
Ooh,
as opposed to feeling like I'm starting from sort of a foundation piece. So I think for BHCs wanting to transition to a behavioral med faculty role would probably be a very different transition than somebody who was coming from an outpatient or a private practice or some other role that they were stepping into.
and I would imagine, not to have a leading question, but I guess here we are. I guess kind of what I'm hearing, and I have some background information
Yes.
on this, but you weren't starting from scratch the way maybe initially your brain kind of went to. You realized pretty quickly, oh, I've been working with physicians. I've been working with pediatricians, as well as, I mean, also some family physicians, right?
Yeah.
So you've been doing this a lot longer. So what advantages did you have, from your perspective, moving into this role, with the fact that you had so much experience in integrated
Yeah.
integrated care?
And I think I had, I mean, just for context for me, I think I had a little bit of an additional advantage on top of that, because being the section chair, so I'm in leadership here at my healthcare organization, and we have integrated care in pediatrics, in family medicine. We have had it in family med residency clinics. We have it in internal medicine. We're in specialty clinics. We're in rural clinics. So we're really broad. And so in addition to like my own experience in primary care and the practice that I'm doing as a BHC, I did have some advantage in the ins and outs of these other clinics, because we're working with them continuously to try to can make integrated care as successful as it can be in their clinics. So I really felt like, okay, well, you have this opportunity and you already have this bucket of knowledge to draw from. So with regards to that, I think I took a couple of things. One is I'm working towards and still working on like the confident humility piece, which is just like, you know, you can achieve it. You've got faith you can you can achieve this goal. And I might not have all the tools right now. And so one of the pieces that was helpful was really advocating for those and what I needed from that. And we can talk about that too. Like, what were those tools? What were those things that I felt like I needed? And then for me, being able to take the advantage of thinking about like, how have I been successful in previous roles? Because I had never been a section chair for integrated care in the past, you know, before I was. I had never led integrated care into internal medicine or family medicine or these other areas. And so thinking a little bit about that was super helpful. One of the things that primarily came out of that for me was, what did I do in those previous situations that helped me to be successful? And then how can I mirror that? And it's interesting when you start something new, you forget that for a minute. Like, oh wait, I've done this before. I actually have these skills. And there's so many of your previous behavioral health consultant skills and leadership skills that benefit you in this role. I think that, you know, one of them that is really paramount to me, even though I promised Bridget I wouldn't say it 100,000 times, but I'm going to anyway, is that you, whenever you're in a behavioral health consultant role, particularly if you're using the functional contextual interview, you do a lot of the skills that will benefit you in this faculty role every single day. We do the functional contextual interview every day with all the patients that we're seeing. And I kept thinking, one of the best ways to support the residents in coaching sessions or in these interactions that I'm having with them is, oh, I should probably do the functional contextual interview with them, not just as a training skill, but actually do it with them. And so getting to understand their context in this as a resident, but also as a person, I think is really beneficial for you coming into the role. It's also really beneficial for them, because I think that the residents often think of themselves only in this residency role, particularly when they're here. And so if you can bring that additional piece to the table, that can really, really be a huge benefit.
Yeah, I'm hearing so many nuggets in here that it's not just this really, oh man, I'm not thinking of the right word right now, but you're not super close to it where it's like, okay, now I have to memorize all these little protocols because now I'm working as a behaviorist. It's you zoom out, very core principles. If you look at the science of contextual behavioral sciences, essentially, there's a function to every behavior. Every behavior comes out of a certain context. No behavior exists in a vacuum. And so if you want to see how to make a change, understand the context from which something is arising. And once you understand that context, then you can work within it. There's always a function to every behavior. And so that's what I'm hearing you say. Like, there's a function to the residents and how they were approaching you, what they were bringing into the room, and you were able to strip that down. And once you kind of saw more clear, I'm assuming you saw things they were nervous about,
Yes.
things that they were excited about, ways to make it digestible to them, the skill set.
Absolutely. And I think there's the skill-based piece, and then there's also, you know, their job's pretty untenable, as you talk about, like this list of skills that our mind might go to too when we forget our own context. But also their job is really untenable to know everything that you need to know in order to provide great primary care to someone from birth to death. That is enormous. And really helping the residents within their context understand what their values are and how what they're doing in the room and how they already have some great skills, helping them to reframe that and think about the context within they're working with, but also the context within they have in other settings, right? Their home life, these other pieces, and bringing that together to bring it really back to their why, right? And helping them to see that whatever they're doing and feeling awesome about their patient interactions, and when they've got some skills to work on for their patient interactions, which we all do. So I think having that and understanding that is vital. And I love what you said about really understanding the context for each of them. I'm thinking about this in a a specific way with specific residents, but also it's not only that, it's also the context of the residency itself, right? And the faculty members that you're interacting with. And so knowing that I think is really important. And one of the first things that I did was not only trying to figure out what's the role from people like you, but also what's it like to be a family med resident here in this specific setting. And so even before CFHA, one of the first things that I did was, well, maybe I just need to come see what this is like. And so I came down and I observed and I just was present and did a bunch of shadowing here to really try to understand what's the context day to day, and really what's the context for the residents in so many of the different hats and roles that they're wearing on a regular basis.
I'm hearing so much curiosity, and you think back to all these business books on leadership and the first 90 days and the
Which,
ones
those two. So
what was that?
I've also read those too, so they're continually in the background.
Well, I think that that's probably a really big reason for a lot of your success is that when you came in, it wasn't, okay, what am I going to impart on all these folks so that they can make the biggest difference? Although that lived probably in the back of your mind. It was like you wanted to learn about their world, their context, from their individual context to the residency context to the learning context, and being able to identify based on all the things that they're juggling, what are they going to be able to uptake? What's going to feel good where it's like deeply anchored in their values? And then starting from there. And you can't tell me that when you go in with that humble, curious approach as a leader, as a faculty, as a BHC, you can't tell me that that's not a huge facilitator of being uptaken and getting that buy-in.
Absolutely. And I was really fortunate to come into a really supportive environment, but both the faculty members, but also the residents were hungry for this, which is, so I do have to say, like, I came into an awesome environment that was just ripe and ready, which is great. And I think that being able to come into this with that curious mindset for your role, for their role, what's the interaction of that going to be? And being able to get at the heart of what is it that you feel that is going to be most helpful in this moment often isn't a tangible skill, which I think is the hard part to keep in mind, especially when you may be sitting next to other faculty members who maybe are engaged in a different kind of precepting than you would. And so I think there's this inherent comparison that can kind of happen in that, which I do think is a good nugget for reflecting on, that it can be hard to compare yourself to other faculty members. And there's some similar roles and there's some different things. And the different I think that we bring, particularly as a behavioral health consultant stepping into this behavioral med faculty role, is magic, right? Like when I find myself falling into like more mechanistic precepting instead of systematic and functionality and in the context, I go back to my core, like, oh, what is that? And why is that? And I think that that's something that we can bring to a setting that is going to benefit and support the residents in their overall growth over their 3 years in their residency program, even more so than, okay, how do I help them in this one patient interaction, which I think is just being able to step back and take that big picture is huge.
I mean, the family systems tradition has been so deep within the behaviorist role or behavioral medicine role. And that's what I'm hearing. Functional contextualism is always looking at the context, family systems, and folks who are systems trained. Not that those are the only ways to be successful. We know, being a behaviorist and all these other, being skilled in motivational interviewing, solution-focused brief therapy, all these different things are absolutely important. But a really key feature, it's not on accident that the family systems tradition is very rich and a long, rich history. And that's that's a lot of what I'm hearing you saying. Speaking of which, so much of your skill set as a pediatric psychologist with children is understanding the context in which the kids are showing up as symptomatic, and what is the context of the kiddos' symptoms, and then kind of seeing in that light, what is the function of their behavior, what is maybe the function of the parents' behavior, how everything sustains each other. So tell me a little bit about that and how you've been able to drop some nuggets on your residents, like to help them see some of what you can see so that they can take that and get to know their patients better and understand their patients.
Absolutely. I mean, you were so helpful in this, I think, particularly in the beginning of helping me draw the connection whenever I was deeply in the imposter syndrome of just, oh, yes, this specifically is a skill set that you have, that you are bringing to this role, which is great, and boosting that confidentiality. But I think that within that, the part of it that we keep hearing a lot about is, okay, so this is the patient, and when you hear it whenever they come to precept, this is the patient, this is their like age, diagnosis, these are the medications that they're on, and this is my plan because this is what their score says. That is really where we started, and I kept hearing these pieces coming back with PHQ-9 scores and G87 scores, really dictating what are your next steps. And one of the things that we can highlight, model for them, and also bring into any precepting conversation with a resident is, okay, and what else is happening for the patient? Like, who do they live with? What is their support system like? What is their work life? Is that meaningful for them? What are their health behaviors like? These pieces that
And
I
what
think
were you getting as responses?
in the beginning, a lot of it was like, I don't know. I didn't ask that.
And now?
And now a lot of it's like, oh, she's asking about context again. Okay. Here we go. Here's those other pieces. I just did a presentation to a large symposium for a couple of healthcare systems for a primary care winter refresher. And I just called out to the residents like, yep, hold on, like I'm going to talk about context again. It's going to come back to it. Like we are going to flash up the functional contextual interview for everyone here again. So I don't know how to do this role without that piece. I don't really know how to do any of my roles without this piece. But I think that for the residents, one of the key pieces was, how do you understand how to do a functional contextual interview, do it in a timely way? Because I think that's certainly something that's always on their minds. And then also, how do we move from all of these demands of checkbox things that we need to do in our healthcare system, and instead recognize that in asking about the context for the patient, you're actually going to get all of that information probably faster. And then whenever you're going to go and talk about interventions with the patients almost always have served you up and laid out what the intervention is going to be for them. And your job is actually just to highlight that. Wow, your job is now much more tenable when we take that lens and we take that mindset, as opposed to feeling like I have to just be a continual like running through a decision tree of exactly what to do over and over again. I think that feels very overwhelming for people. And so bringing that context to it is so vital. It's something that we do in pediatrics every day. I don't know how to work with kids and not do that. And I think the light bulb for me was, of course, that's exactly what we have to do with our adult patients as well. Really, we're doing the same things. And when we understand their functioning in their context, then the interventions lay out for you, and you're able to get that support not only in the buy-in from the resident themselves, but also from the buy-in from the patient, and then they have more success, whatever that happens to be in the moment for them, or how they're identifying it, and then they come back for more, and they're more curious about it. Like, okay, how did we ask those questions? Can you show me how you might ask this question, or and how I can get that information from my patients that I can understand a little bit better, and not just increase a dose of medication.
And I know, first of all, that was pure gold. So if you're watching this on a PCBH Corner, well, I guess that's the only place you'd be watching. If you're watching on YouTube, I would rewind that. All the stuff that Dr. Allmon Dixson just said, rewind it and re-listen to it, because that was absolute pure gold. Tell me a little bit about when you first started mentioning the context. So you said that the folks at your residency, the residents themselves, they were excited. They wanted to learn more about this. And I mean, were they surprised when your big intervention was, so you need to go learn more about them, or so you need to go gather more context?
Yeah. Questions.
Yeah. So tell me a little bit. I'm so curious about when they first were introduced to some of these tidbits, and then when it kind of started maybe working for them, because I know you have buy-in now, and you don't have buy-in if whatever you're doing is not helpful. So yeah, walk me through a little bit of that.
Yeah, I mean, I think that there were So one of the pieces is the timing with which I came into the residency was so helpful. And I don't know if people know, when new residents start. But one of the reasons that I started in May and tried to kind of get my ducks a little bit in together was so that I could be ready for the intern class. And so that whenever we start with a new intern class in, late June, then I was a part of their beginning in the residency. So that was really great. I mean, obviously, I'm still focused on the second and third years too. And it was so awesome to be able to start with a new class as well. One of the things that we did was we built the contextual interview right into the orientation process. So whenever they asked about, okay, what are some things that you think would be helpful to talk about with the residents? What is it that you want them to know? There were certainly pieces that the residency had laid out, like, we want to talk about suicidality, which I did in a functional contextual way. I want to talk about what are the resources, which we can also do in context. So there were definitely some pieces and some like didactics and supports that they wanted me to give. And then there was this beautiful open place of, okay, what is it that you think, like, we've got this time, what is it that you think would be most beneficial to them? And so the first thing that I did was reach out to you and said, all right, how have you done this in the past with a new group of residents? And so benefit from that collaboration. But then being able to take that and being able to do it from day one with they actually had me, I think, day one, which is interesting. So they put the behavioral med faculty right at the top of the list for doing this. But they had me at the very beginning. And one of the first things that they're ever hearing about working in the residency, how we're going to, support patients here, how we're going to support you here is by looking at context. And so whenever you start off that way, I think it's such a good foundation for them to know, okay, anytime I come and talk to Dr. Allmon Dixson, this is the lens with which she's going to bring some sort of intervention or some sort of support. And so these are the things that she's probably looking for. And how am I going to use those things? And then really what it is it's taking that, it's getting actual practice, which I think is so important because we can talk about it all we want. A didactic lecture is what it is. But really you've got to get actual practice, both in ideally like some Sims situations, but then also in exam rooms with patients. So then it becomes, how can I model this for them? Now that we've talked about it, we've sort of done some sims, we've done some layering. Great. Next time you go in with a patient or you're seeing a patient and you're reviewing their chart and saying like, oh my gosh, I'm not looking forward to seeing this, or this is going to be really challenging. Look at all of the previous history. That would be a great one. I'd be super happy to come in. Let's do this together. So then they get to see it in real life. And sort of the thing that I like to think about it is and I often say, just try it on. Yeah. See if it fits for you. And so them having that repetition and that practice, I think, is so key. And the part that I'm noticing for the second and third years is there's more and more ask about it and more request for the functional contextual interview. So because they missed that part, right? They didn't get it in the same way that the intern class did. And then one of the awesome parts about it, I think, was then we do faculty development meetings, and then my faculty development asked for the functional contextual interview. And basically I did very similarly what I did for the residents. And actually I'm doing part 2 coming up in a couple of weeks. So for the faculty development. So I think that the request and sort of sitting back and being able to let the skills that and that you've got in your BHC role shine and support the residents, and then letting them come and ask and be hungry for more, I think is such, at least, okay, I have an experience of one residency, but it's such a better experience than trying to come in with a set, didactic, how you'd exactly like everything to go and trying to get people to buy in. I think if we let the skills speak for themselves, then they're going to come back. They're going to want more of those. They're going to see the success. They're going to have it. It's going to benefit them not only in the work that they do, but being able to set the work down that they do whenever they leave. And go home and hopefully go into their other contexts that are supporting them, and so I think it just has long-term success and buy-in and support for them in their time in residency and hopefully after that.
One of the things that myself and Dr. Bauman find ourselves saying, had to bring Dave along on this PCBH Corner.
Hey,
not here.
This is a collaboration.
He always says, from what he's learned with working with primary care providers, family medicine physicians. He always says, they are some of those most pragmatic people on the planet.
Yes.
So the key to their heart is you give them something that's useful. And so that's what I keep hearing when it's like you let the skill set speak for itself. You show how you demonstrate how knowing about this person's living situation, their relationship status or support, their family support, their friend support, their belief system, their work life, their what they do for fun, what they're interested in, their hobbies, interests, passions. If you can learn about their love, work, play, how does that actually allow them to help this patient better in their medical context? And that's what you're obviously proving that it's useful, because there's no way in hell that people would uptake that if it wasn't useful, especially because on the surface, as we were saying, it kind of sounds like, so you want me to ask more questions and to do more. And at first that's like a really hard sell. Like,
Yeah.
oh yeah, by the way, you're super stressed out, you're seeing a ton of patients, you have limited time. What I want you to do is go do more. And so it sounds very paradoxical.
Yes.
But like you were saying,
Until you see it work.
so you see it work.
I think that that's the part that, and that was the key, I think, in doing this is at one point I would like to talk about like the PDSA version of all of these things, but I think the key of doing this was I first piloted the functional contextual interview presentation and like didactic that I was going to do for orientation with a third year who was on their way out. So they were literally leaving the residency, a couple of weeks after I started. And so I did it with them. And one of the things that they said to me, which is so true, and I say it all the time, but didn't have it on a slide, is this is permission to do less, actually. It's a way to make everything that you're doing that is untenable, tenable. And I just thought like, oh my gosh, I'm literally stealing those words and putting them on. So I'm going to say it 10 times. Because I think that is the part that everyone needs to hear. And it's the part that I also think that until you do it, you don't believe it. So you've got to get that practice to know, okay, I did ask fewer questions. I do have a good picture of the context for the day. I don't have to ask any more of these questions. I've already got it. And you know what? The patient, as they were talking about these things, actually gave me everything about the presenting concern. And I didn't have to ask any questions about that. Wait a second. I was going to go down a whole rabbit hole asking all of these yes, no's. And I didn't have to ask any of those because they told me when I asked them about their context. So I think the proof is in the success that they have, and that builds their confidence in what they're doing. And I think that the other piece that sits with me so well for the functional contextual interview for residents is that it really gets at whenever you talk to them about, I always ask my BHCs whenever upon hire, like, what's your why? Like, what are your values that are driving this work for you? And how can we keep that at the center of your work when things get hard? Because things will get hard, right? There will be awesome moments and there will be moments that you feel like you're wading through mud. And so how do we keep that at the center? I think that this gets at the center for the residents too. They want to, and when I asked them about that at the first time that I met the intern class, like, what is it that drives you in this? What is it that keeps you focused on wanting to become a family doc? And it's almost always about patient stories, understanding your patients. And it's like, well, great. I have an awesome way to help with that. And it goes from this checkbox piece where you feel like you have all these untenable things to really getting at the heart of why they want to practice medicine. And who doesn't want to keep coming back to that, every time they leave an exam room.
Dang, I just want to like drop the mic. I was trying to take a look at my notes. I'm like, is there anything that we haven't asked yet? But at this point, I knew that this conversation was going to produce something awesome. I didn't know what it was going to produce, but I knew it was going to be awesomeness, and it was. And so I'm so excited. There's other stuff running through my head, but I'm going to stop with my questions and just kick it back to you and say, basically, is there anything else that I haven't asked you about that just kind of is on your mind or on your heart that you think you'd want to share with somebody watching this PCBH Corner?
Yeah, I mean, I think when I think about, especially if we're thinking about the kind of target audience, which you'd mentioned at the beginning, I think there's a couple of things that I would think with regards to the residents themselves. I think one is ensuring that your role in this behavioral med faculty piece really helps to model that residents are also individuals, they're people in their own context, not just residents. And so understanding all of those and the intersectionality of it, I think is really invaluable. And I also think it's a really good nugget for the residents too. Like, it helps you do a better job in your role, but it also is something that oftentimes needs highlighted for them. They come in with such amazing strengths and such great context that have helped them get to where they are right now. How can we help to highlight that and use those similar things to propel them forward how they want to? I think the other part for me is that I'm a continual PDSA in all my roles. You are as a BHC, if that's the role that you're in right now, you will be in that similar way as a faculty member. And because of that, I think making sure that we're learning something from everyone we know and we keep asking these questions, I think is how we keep getting better. If how I am as a behavioral med faculty looks the same in May as it does right now, I probably haven't done a great job. I say the same thing to my team, like integrated care is continually shifting and changing, and it should, right? And the same thing for this. And then the last part that I just want to highlight is that within like the initial piece of trying to figure out, is this for you? I think I asked probably 6 or 7 people across the country, which I think is super helpful. I also think that things are done in really different ways, depending on which residency that you're in. And behavioral med faculty roles look really different, I think, depending on where you are. And so for me, finding people that had similar whys to mine was so important. Because it showed me how I could be in this role and how that could align. And I think that if I'd stopped after speaking to the first person, I probably would not have stepped into this position.
Interesting.
Because their role was different and their why is different, not less or bad in any way, just different than mine. And so I think making sure that you get multiple perspectives is incredibly helpful, so that you can, there's some great, amazing piece of this that you get to mold too, you know, and you get to mold it with the great team that you build around you, like the colleagues that are you and the other colleagues around the country that I've been able to bring onto this team. And then also, whenever you're developing things in the residency, you have everyone in your residency clinic who's been here much longer than you in most places. And I've never been a family med resident. So as we're continuing to mold this and continuing to do PDSA cycles, I ask for more feedback every single time. Every opportunity creates another opportunity to get more data. So every time I do a coaching with a resident, I ask them how it went. Whenever we created the curriculum, I asked them, what do you think? Like, how do we keep moving this forward and how do we make sure that it's what you need? And that's going to be a collaborative effort. So yeah, I'm really excited about the work that we've done. And I think it'll just keep getting better and better from here.
Well, this is exciting stuff. And myself, Matt Martin, Amber Cahill, Dave, and one of their physician colleagues, we partnered together to create an article, and it was just accepted into medical education online, I believe. And we basically talk about the contextual interview as being a really important part of helping folks to get instead of it being the history of presenting illness, you know, your traditional HBI, that's pretty static, to have a dynamic. And Matt and Amber were able to basically match the items in the contextual interview to the milestones. And we're able to identify that so many of the milestones, are related. Like, this would be a skill set that would hit on that.
It is directly related.
Yes. And so that article, we just got the proofs for it. It'll be coming out very, very soon.
Amazing.
And
can't wait to read it.
And we snuck in XSV about assessing the ACEs and cultural considerations, context, internal context or external context, social determinants of health, stage of change, and value. So we snuck a lot into that article.
Amazing.
So
that is going to be, I mean, you're asking like where are the resources for people stepping into this role? That's going to be a resource into this role. I mean, reviewing the ACA-GME requirements is great. Being able to map it onto some skills that you already have. And that's the word. That's what needs to happen, you know, and I think thank you so much for putting that out there. That's going to be such a huge asset to everyone who's doing this. And my team will get it, and then I'll disseminate it and have them all read it.
Amber and
sit in the intern classes, didactics next year. It's going to be great.
Right? Yeah, Amber and Matt, they were the ones that did that mapping. They're the ones who came up with that idea. And so they just, utilized Dave and I for our knowledge of the contextual interview. But it was really their hard work. And I couldn't not share that. I was going to say in the beginning before we even started filming, but I was like, you know what, I'll share it with her on screen. Because you were worried you might say context too much. And then I'm like, you know what? You can never say context too much. So boom, gonna drop that.
Love it. Put it in there. Add a link and a published date at the bottom.
Oh, you know it. you see, yeah, you know how we roll with that. Well, this was pure gold. This entire video is pure gold. I hope that if you're out there that you find it as helpful as I did, even though, I'm in this role, I've been doing this role for a number of years. It's still helpful for me to hear. So I know it's helpful for folks that are going to be starting out. It doesn't even matter what stage you're in. If you're starting out, or you're thinking about going this direction, or you're well into it, I think that this was pure gold. So I just appreciate your time and your eloquence. It was really inspiring, and I can't even tell you how many times I got chills as you were describing things of just like, yes. So thank you so much for joining the PCBH Corner.
Well, thank you so much for having me, and thank you for all you do to support this. This is, having the consulting piece has been so vital to the success here. And I think that it's really one of the parts that I took away from those first conversations was you've got to consult with everyone around the country. Was like, who are you going to talk to on a regular basis? Who's going to, go through this with you? And I think that having that was so great. So highly recommend that to anybody who's thinking about stepping into this. Is just gather your team around you and insist on that time, because you need it. You need to be able to have someone to bounce things off of and to grow with, and who's creating great additional resources while all of that's happening, so you can incorporate it later. So thank you so much for having me. This was really fun, and I look forward to continuing to learn more.
This was super fun. All right, guys, thanks so much for watching. I appreciate y'all.